the ambassadors, moderators, speakers, and the delegates who are logged in from all over the world for this international webinar series. I am Dr. Chandrasekhar, your governor for American College of Gastroenterology India region, and I bring warm greetings from ACG as a member webinar subcommittee, and I also bring good wishes from World Gastroenterology Organization as a member of scientific committee, as the honorary professor from the Tamil Nadu Dr. MGR Medical University. I bring warm greetings, and from my institute, Medindia Hospital in the academy, which is organizing this international webinar series. The earlier two series of webinar, I have noticed that 19,000 delegates from all over the world have viewed this webinar series. That was in the peak of COVID, but we are very active, and I'm glad that many faculty from United States and rest of the world, and they attended as the eminent faculty for our international webinar. And you have seen the delegates who have really logged in from many countries all over the world. Now we gave the name tag, name the topic, the world experts are here, and it created a news, yes, new ENDO-GE webinar series, and it is a live webinar. And after seeing the stupendous success of our previous webinars, we have organized 12 webinars starting from April 2025 to March 2026. The first webinar series was inaugurated by Professor Dr. Jonathan Lighton, who is the president of American College of Gastroenterology. And all these webinar series have been endorsed by American College of Gastroenterology. It became very easier for us, the third webinar, to get the endorsement because we proved our worth in the first two series of webinar. They identify the quality of the webinar, so it was easy for me to get this. And one of the noteworthy, the faculty who addressed this platform is Professor Dr. Barry Marshall, Nobel Prize winner, Nobel laureate, discoverer of Helicobacter pylori. Several thousand people attended this webinar and benefited from all over the world. This webinar would not have been possible with the hard work rendered by my colleague Dr. Gokul Satya, Yogesh, and Dr. Prasad and Trinyana Sambandam. And now we have made this webinar every month, Thursday, so that, and you see the kind of eminent faculty we have, starting from Gorda Chaudhary, Usha Datta, Mahesh, Amit, and Ramakrishna, and international webinars, so many people have an eminent national faculty also, Dr. Nagi and Dr. Sarin, Dr. Rande, Dr. V. Mohan, and Shashank Joshi, and Narasingan. And what we have done is, so all the eminent faculty, we have really requested them to be moderators for this webinar and panelists. Again, adding richness to the value and the importance of this webinar. You been noticing that they all lined up 12 webinars all over the every month, starting with a topic like type 2 diabetes, diabetes in GI tract, systemic hypertension and portal hypertension. Today, the current management of dyslipidemia and the management of fat and liver, and the other topic is going to be a pharmacotherapy of obesity and the endoscopic and surgical management of obesity, doctor and law, doctor and ethics, doctor and research grants, and the doctor and finance, doctor and entrepreneurship, and research methodology. Two sessions we are going to have that. Then what is the role of master health checkup in gastroenterology? how to pick up precancerous lesion in gastroenterology, screening methodology and management. And February 13, 14, 15, we are going to have live demo workshop on digestive endoscopy called a DUE. And last but not the least, March 12th, the debate on endoscopy versus surgical gastroenterology, gray areas in gastroenterology, physician perspective and surgeon's perspective. We have eminent faculty from all over the world, and today's topic is current management of dyslipidemia in 2025, fat and liver storage to damage, how to manage it. And with this, I have a very pleasant duty to tell you that we have eminent faculty both from internal medicine and gastroenterology, and both moderators, and I'll be very glad to introduce them as a faculty introduction. Professor Narasingan is the director of SSN Specialty Chennai, the vice president of World Hypertension League and chairman Association of Physicians of India, Chennai chapter, vice chairman Lipid Association of India, immediate past president Indian Society of Hypertension, former adjunct professor at Tamil Nadu Dr. MGR Medical University. He will be the first speaker that will be moderated by Professor Dr. Yogesh Chawla. He is a chairman of academic Kalinga Institute of Medical Sciences, Bhubaneswar, and a former director of Postgraduate Institute of Medical Education Research, Chandigarh. He has been a mentor to many postgraduates from PGI, honorary president of Indian National Association for the Study of Liver, and he has been my predecessor as the governor of the American College of Gastroenterology, India region. He is the recipient of several awards, including Bloomberg Oration Award. And the second speaker is Professor Dr. Gauradas Chaudhary. He is the Director, HOD, Department of Hepatobiliary Sciences, Fortis Memorial Research Institute, Gurugram, and a former professor, head and Department of Gastroenterology, Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. And he has been the honorary secretary and the president of Indian Society of Gastroenterology. He introduced very new innovative idea like gym and so many other programs. He has 200 publications to his credit, and he has been bestowed with several awards, including Lifetime Achievement Awards. And another eminent gastroenterologist from Kerala is going to moderate the second speech. The second talk is Director of Center of Excellence in Gastroenterology Science, Rajagiri Hospital, Kochi. There is none other than Professor Dr. Philip Augustine. He is the founder, Lakeshore Hospital Research Center, Kochi, Padma Shri Awardee, and recipient of Olympus J. Mitra Award, Endoscopy Award. He has been the president of Indian Pancreas Club. And have very eminent gastroenterologist panelist, Dr. C.C. Chaubal. He is one of the senior most gastroenterologists from Bhopal. He has been very active. He continues to update his knowledge every day. I'm glad to have you, Dr. Chaubal. And Dr. Praveen Kumar is professor of gastroenterology, Government Medical College, Kannur, Kerala. And another junior colleague of mine, who had worked earlier in government institution, now consultant gastroenterologist, Medanta Hospital Patna, is Dr. Ashish Kumar Jha. With this introduction, I will fail from my duty if I don't introduce how this webinar became popular, because we have ambassadors from all over the states in India, and from Madhya Pradesh, Dr. Chaubal, Pravir Roy, Ramesh Kumar from Telangana, Srinivas Rao from Andhra Pradesh, Praveen Kumar from Kerala, and Aravind Gobi from Karnataka. And you just see the Mahapatra from West Bengal, and every state will have an ambassador for us. And we have international ambassador from USA, Malaysia, Nepal, and Bangladesh, Nigeria, and rest of the countries, including Australia and Sri Lanka, Myanmar. So now my duty is to call upon our first moderator, Professor Chawla, to introduce the topic and invite Dr. Narasingan to deliver his first talk on management of dyslipidemia in 2025.
Thank you, Dr. Chandrasekhar. Your introduction to your program has been excellent. And the speaker that you have chosen is absolutely the right person who's done extensive work on lipids. As a hepatologist and a gastroenterologist, we had never thought of the importance of dyslipidemia in our field till we started learning about metabolic associated fatty liver disease. And that is the time when we came across these abnormalities clinically in our practice. So I think it would be a pleasure to listen to Professor Narsingan, his opinion on the current management of dyslipidemia, and I'm sure every one of us listening to him would benefit from his lecture. Welcome, Dr. Narsingan.
While you're starting, I request all of you to disappear from the screen, but for the moderator, and please mute yourself. I just saw Dr. Gordas Chaudhary on the screen. We just introduced him also, okay, and just introduced him also. Then the over to Dr. Narasingan as Dr. Chawla invited.
Can I just share my screen?
Yeah, your slides on.
Yes. Good evening, everyone. I am really happy to get associated with all of you, particularly the gastroenterologists, and take part in this international webinar on gastroenterology. I really appreciate Dr. Chandrasekhar for this Herculean task of arranging these meetings every month for a period of 1 year, and he has involved many gastroenterologists and even other specialists also into this particular international webinar. Let me thank him profusely for the opportunity that he has given to me. The current management of dyslipidemia in 2025. Let me now try to take you to our understanding about the burden of the atherosclerotic cardiovascular disease. In fact, the cardiovascular disease is the leading cause of death it is about 31% of all deaths globally are due to the deaths that are occurring. About 31% of them are due to cardiovascular disease. In Europe, it is about 45% of all deaths. 23% of all deaths are due to cardiovascular disease in the United States. CVD is also a leading cause of premature death and accounts for about 6.2 million premature deaths globally every year in people aged between 30 and 70 years. Let us now try to concentrate on cardiovascular disease in our country. It is again the most common cause of death in India. The estimated prevalence of cardiovascular disease in our country is about 54.5 million people. It accounts for about 24.8% deaths among Indians between 25 to 69 years of age. The recent publication is ICMR INDIAP study, which actually got published in Lancet in the year 2023, which indicated not only the increasing prevalence of diabetes, which had gone beyond 100 million, but it's also indicated that the prevalence of dyslipidemia is around 81.2%. If you look at this projection, which was published last year, which clearly indicates the percentage of various forms of dyslipidemia. Hypercholesterolemia is about 24%, hypertriglyceridemia is 32%, low HDL cholesterol is nearly 67%, high LDL cholesterol is 20.9%. If you look at the pattern of dyslipidemia, there is higher triglyceride levels and low HDL levels. It not only occurs in Asian Indians, it is much more common in Indian population. The increasing coronary artery disease morbidity and mortality in our country. Nearly 40% of the Indians with the coronary artery disease are less than 40 years of age. That is the most worrying problem for all of us to tackle this condition of coronary artery disease. 25% of those dying due to coronary artery disease are less than 40 years of age. In Indians, coronary artery disease develops 1 decade earlier than other ethnic groups. More severe coronary artery disease and high mortality. Taking all these evidences into consideration, the ACC has considered Asian ethnicity as a high-risk group. Having seen this, I must tell you that there is a mention about atherosclerosis in the journal called Arteriosclerosis, which arteriosclerosis in the year 1933. In the absence of hypercholesterolemia, particularly the raised LDL cholesterol or remnant particles, it is virtually impossible to cause atherosclerosis in an experimental animal. It is true even today that LDL cholesterol is the most important culprit in the atherosclerotic process. Not only the LDL cholesterol, but all the remnant particles are very important not only in the initiation of atherosclerosis, but also in the progression of atherosclerosis. Having seen this, I must tell you that there is a huge study, an epidemiological study conducted by Salim Yusuf and his group called Interheart Study, which had evaluated 9 commonly occurring reversible cardiovascular risk factors and had come out with the data showing that the population attributable risk is about 50 when compared to the other 8 risk factors which were taken into consideration for the first attack of myocardial infarction. It was conducted in about 52 countries and nearly about 15,000 participants, which definitely has got an important role to play to all of us to show that the cardiovascular risk factors, out of all the cardiovascular risk factors, it is a dyslipidemia that is the most important risk factor for acute myocardial infarction. This projection is from the Cardia study. In the one that is on the y-axis, the lower one is blue, it is asymptomatic plaque progression. The red one is actually the imaging of a risk, which is actually going for an acute coronary syndrome. In case the lifelong exposure has got an impact in pushing patients for an acute myocardial infarction, if somebody has 80 milligram of LDL cholesterol throughout his life, the chances of getting myocardial infarction is at the age of 100 years. If someone has 125 milligram of LDL cholesterol throughout his life, it is common to get about the problem around 64 years of age. If someone has 200 milligrams and above, for example, familial hypercholesterolemia, where you have more than 200 milligrams of LDL cholesterol, or familial hypercholesterolemia, both homozygous and heterozygous, you have more LDL cholesterol values. Such people are likely to get myocardial infarction before the age of 40 years. So this is the most important valid information what I thought I should share with all of you, because this most important data to talk about the problems of LDL cholesterol and its implications in producing atherosclerotic cardiovascular disease. The role played by LDL cholesterol, actually, number of evidences are available with us now. One is the molecular studies, the biological information, huge epidemiological studies, observational data. In addition, the Mendelian randomization studies. In addition, we also have the randomized control studies. I like to project the randomized control trials, which are very important. The more reduction that was observed by using the HMG coenzyme reductase inhibitor statin, that had resulted in the marked reduction of cardiovascular events, not only for morbidity but also mortality. That shows more the reduction of LDL cholesterol that are seen in primary prevention trials, in secondary prevention trials. We were able to appreciate that there's a good reduction in morbidity as well as mortality as the risk is concerned. So the emphasis is only on LDL cholesterol, and we should see that it must be lower, or it should be kept low throughout our life. Let me now try to tell you about the lipid-lowering drugs which are available at our disposal. Lovastatin, fluvastatin, pravastatin are no longer available in our country. Simvastatin again has disappeared from our Indian market. Atorvastatin, rosuvastatin, and pitavastatin are available with us. They are all HMG coenzyme reductase inhibitors. Gastrointestinally active drugs are bile acid drugs in anion exchange, like cholestyramine and cholestypol. The lipid-lowering drugs in this, you have a bar non-absorbable polymer, that is a cholecylamine, cholesterol absorption inhibitor, that is ezetimibe, niacin or nicotinic acid, again disappeared from the market. Fibrates, you have gemfibrozil, bezafibrate, fenofibric acid. Omega-3 fatty acids, you have docosahexaenoic acid and eicosapentaenoic acid, and the pure form of EPA is icosapent-ethyl ester. The most recent drugs that were introduced into the market globally and that too even in our country it is available now, or the PCSK9 inhibitors. This protein is secreted within the liver cells, proprotein convertase subtilis in kexin type 9, and that gets inhibited by these monoclonal antibodies. One is avalocumab, the other one is alirocumab. Then also we have another drug called bempedoic acid. Then you have inclisiran, then you have evinacumab. I would like to tell you something about the statins, which had been with us for the past 3 decades or so, and we have actually good amount of evidence for its safety as well as its efficacy. No doubt it has prolonged the lives of millions of people, prevented the problems of ASCVD, including coronary events, stroke events, and revascularization procedures were also coming down to the usage of these statins. If you look at this data, which shows the primary prevention on the lower scale, secondary prevention on the upper one, which many studies have been conducted with the usage of these drugs. So the more you get the reduction in the LDL cholesterol, the more important is to appreciate the events are coming down. So the more the reduction in the LDL, the more reduction in the event rates are appreciated, not only in primary prevention, but also in secondary prevention trials. I would like to tell you about one primary prevention trial that is called Jupiter trial. One arm received the 20 milligram of rosuvastatin, the other arm received only placebo, and observed for a period of only 12 months in the beginning to start with, observed for a period of 3.4 years or so. And it's a primary prevention trials with no baseline cardiovascular disease. And these people have shown a good reduction in the LDL cholesterol. What was seen initially as 108 came down to 55. 50% of them actually reached the levels less than 55 milligrams. 25% of them reached less than 44, and 23% had reached the levels of 40 milligram. I need to tell you it is a primary prevention trial conducted in people without any baseline cardiovascular disease. The investigators wanted to see whether there is any effect of statins on the high-sensitive CRP. With that in mind, the study was started. But finally, they ended up getting all these details with respect to the LDL cholesterol reduction and even the reduction in the cardiovascular events only with the anticipated reduction of the LDL cholesterol. There were no safety issues identified in those with the LDL cholesterol less than 40 milligram. That is the most important information what I thought I should share it with you. Nearly 44% relate to risk reduction in the primary endpoint at the end of the study, 20% reduction in the total mortality, and non-fatal MI reduction is about 65%, something amazing results. So primary prevention study, that is a Jupiter study, has shown the way for us to proceed further in managing people for the reduction of cardiovascular events. The same study had given yet another information. People who had reached the levels less than 50 milligrams of LDL cholesterol on rosuvastatin 20 milligram has shown marked reduction of cardiovascular events when compared to people who were keeping the levels above 50 milligrams of LDL cholesterol. I will show you another study. This is a secondary prevention study called PROVE-TIMI 22 study, which was conducted in people with acute coronary syndrome. One arm received 80 milligram of atorvastatin, the other arm received moderate dose statin, that is pravastatin 40 milligram. And in fact, these people had started this drug soon after acute myocardial infarction. You can just see the post-hoc analysis clearly shows that keeping the reference value between 80 and 100, you can see people with the levels of 40 milligram and less than 40 milligram has shown much more beneficial effects in the reduction of cardiovascular events to the extent of nearly 39%. So if you reduce the LDL cholesterol to less than 40 milligrams, you can anticipate a reduction of nearly about 39% in the risk in those patients with an acute coronary syndrome when they received high dose of statin, particularly atorvastatin when compared to the moderate dose statin, pravastatin. So these two studies had clearly indicated the beneficial effects of statin. The message is very clear. If you are able to bring down the LDL cholesterol to 50 milligrams or so, you will get a benefit of reduction of events for more than half. But surprisingly, the real world scenario has given this information that most of the patients, even on high dose statin, nearly 40% of them do not reach the LDL goal of less than 70 milligrams. If you look at this projection, which gives you important information from the meta-analysis, which had included a lot of randomized controlled trials, which had involved 26 randomized controlled trials on the top, 49 trials in the middle, and 52 trials in the bottom, which had used not only statin with ezetimibe, different drugs, statin, ezetimibe plus PCSK9 inhibitor. The conclusion, which had given by the cholesterol treatment trialist collaborators, clearly tells you that if you are able to bring down the LDL cholesterol by 1 millimole, that is equal to 38.7 milligrams, you will definitely get a reduction in the cardiovascular events to the extent of 20% or 21%. That is something amazing results which we had obtained by all this meta-analysis. So how to reduce the LDL cholesterol? Lifestyle modification is the most important thing which we need to be advised for each and every patient who is seeking advice, not only for the first time, even for the subsequent time when the patient seeks advice. Statins are the best drug which need to be started in the beginning. Combination therapy are definitely required when you are not able to reach the goal what you want in a particular individual with the risk which is associated with that particular case. Oral combinations, ezetimibe, bile acid questions, though it has shown some beneficial effects in the reduction of cardiovascular events, but it is not acceptable to many of the patients. They have developed a lot of side effects not being used routinely. Bempedoic acid, obicetrapib. Obicetrapib is a cholesterol ester transfer protein, CETP inhibitor, which has assumed a lot of significance in the recent past. It has shown that it reduces the LDL cholesterol and it also increases the HDL cholesterol to some extent. Oral PCSK9 inhibitors, phase 2 studies are over. We are expecting much more information in the coming years. Lomitopide is an MTP inhibitor which is useful only for treating patients with homozygous familial hypercholesterolemia. On to the right side, you can see injectable. There are the monoclonal antibodies like PCSK9 inhibitors like evolocumab and alirocumab. Inclisiran is yet another drug which is actually a small interfering RNA. Evinacumab is a drug which is reserved mainly for treating homozygous familial hypercholesterolemia. Now we'll look at the moderate dose statin, high dose statin. What is the potency of these statins to reduce the LDL cholesterol? If you look at the moderate dose statin, it can produce a reduction of about 30%. If you use high dose statin, it can probably reduce the cholesterol by 50%. If you take high intensity statin with ezetimibe for your patient, probably you can expect it to come down by 65%. The last one, ladies and gentlemen, please concentrate on that. If you are using a high dose statin plus ezetimibe plus PCSK9 inhibitor like avalakmab, you can expect a reduction of nearly 85% in the LDL cholesterol. That is the most important information what I thought I should share it with you. Let me now try to take you to ezetimibe. Ezetimibe blocks this. The Niemann-Pick C1 like L1 is the one that is blocked, and that is the cholesterol absorption inhibitor ezetimibe, which was tried in this particular trial called Improve It trial, which was conducted in people with acute coronary syndrome. Nearly 18,000 patients were recruited for the study. One arm received only simvastatin 40 milligram. The other arm received ezetimibe over and above simvastatin. Ezetimibe is a cholesterol absorption inhibitor. Look at the data. Within a matter of 1 month, you can get the drop in the LDL cholesterol, which has gone and touched the levels of 53 milligrams, which had resulted in the relative risk reduction of 6.64% in the primary endpoint. But what attracts my attention is that you need to concentrate on this projection, which is the Kaplan-Meier curve. On the top, you can see dotted lines, which is actually the placebo plus simvastatin, whereas the yellow line indicates the simvastatin plus ezetimibe 10 milligram given for those patients with the diabetes, which has shown much more beneficial effects of nearly 14% relative risk reduction. Where is 6%? Where is 14%? So I need to tell you that adding an ezetimibe to the statin with a high dose probably will definitely give benefit for those patients with the diabetes. It is also true that people with the diabetes, when they have polyvascular disease, it's not uncommon to see people with the diabetes getting problems of stroke as well as a coronary artery disease or a peripheral vascular disease. If they have a polyvascular disease, it is the drug of choice. It will be high dose statin with ezetimibe. Let me now try to take you to our understanding about the PCSK9 inhibitors and its usage like avelumab and alirocumab. The good old studies. One is the Odyssey long-term study which had compared placebo with the alirocumab, and Osler 1 and 2 which had compared the standard of care with the avelumab, which has shown a reduction of nearly 50 to 60% LDL-C reduction, and that resulted in about 50% risk reduction. Very simple to remember. If you are able to reach 50% reduction in LDL cholesterol, you will definitely get a 50% reduction in the cardiovascular events. Proven. Taking all these evidences together, Lipid Association of India in year 2016 came out with the recommendation that we need to reduce LDL cholesterol to the levels of less than 50 milligram in very high risk individuals. Let me now try to take you to the other study, most important study, which had used the avelumab, that is a 4-year trial, which got published in the year 2017 after we published the earlier information. This study actually conducted in those people with the established cardiovascular disease, like prior MI, prior stroke, or symptomatic PAD. Nearly 27,000 participants in this study. One arm received avelumab, which was given subcutaneously, 140 milligram once in 2 weeks, or 420 milligram once a month, compared with the placebo. The results are amazing. Just look at the end of 4 weeks, the levels of LDL cholesterol touched 30 milligram. At the end of 48 weeks, it got stabilized. And throughout the course of study, nearly about 3.2 years or so, that continued to be around 30 milligram, 30 milligram. So that is the most important message which is obtained from this particular study. Till that time, we were all thinking that lower is better. But this study has changed this concept that even the evidence is coming for lower is even better. In fact, this study has shown that there is a reduction nearly about 15% in the primary endpoint when you are reaching the levels of LDL cholesterol to 30 milligrams. The most important data that I thought I should tell you from this study, at the end of 4 weeks, people observed the LDL cholesterol reduction. People who reached the levels of even 10 milligrams, less than 10 milligrams of LDL at the end of 4 weeks, they were all followed up throughout the study. They had come to know that people with the levels of 10 milligram had shown a maximum benefit of 31% reduction when compared to only 15% reduction for 53 milligrams, 30 milligrams. So for 30 milligrams of LDL cholesterol level, we had obtained 15% reduction, the primary endpoint. For those patients who reached the levels of 10 milligram at the end of 4 weeks, when they were all followed up, you are surprised to see that 31% reduction in the primary endpoint. That shows the more the reduction in the LDL cholesterol, the more benefit that we can obtain in the cardiovascular risk reduction. It is also true that it was the Glagov study, which had used the avelumab for reduction in the percentage atheroma volume, which was seen as a positive effect by using this combination. Another trial called alirocumab, which was used in the Odyssey outcome trial, where they used alirocumab 70 milligrams subcutaneously, given again once in 15 days, compared with the placebo. In those patients with the post-ACS, nearly about 19,000 patients, 29% of the patients who were recruited for the study were with the diabetes. Again, it has shown the same 15% reduction in the primary endpoint, what you are seeing in this other study, that is a 4-year trial. But what is important here to appreciate in the Odyssey trial, people who reach the levels of 15 milligrams, they have shown the maximum benefit of nearly 29% risk reduction compared to people who are keeping the levels around 73 milligrams or so. So advantages of PCSK9 inhibitor, both avelumab and alirocumab, not only reduces the LDL but also VLDL, non-HDL, lipoprotein little a, remnant lipoprotein particles, and LDL particle numbers are all coming down. Inclisiran, yet another drug which probably really attracts our attention. It is available in Indian market. It is a small interfering RNA that mimics the body's process of RNA interference to prevent the production of PCSK9, thus increasing the LDL receptors on the liver. Once the LDL receptors are actually increasing in number, they will take away the LDL cholesterol down. So this particular study has shown an important information that 50% reduction in the LDL cholesterol can be obtained. And not only that, the PCSK9 levels are also coming down. The concentrations of PCSK9 are also coming down with usage of the small interfering RNA inclisiran. Does inclisiran reduce the cardiovascular events? This question is answered only with the small data. About 3,655 people who were recruited for the study in this 18 months follow-up only, which had shown reduction of LDL cholesterol to the extent of 53 milligram, which had resulted in the reduction of events by about 25%. It looks as though it is a good drug which requires long-term follow-up for us to understand, but the cardiovascular outcome data is beneficial. Bempedoic acid is a good drug which acts at one level above the HMG coenzyme reductase. This enzyme is the ATP citrate lyase. This enzyme gets blocked. As a result of that, the upregulation of LDL receptors occurs. The LDL cholesterol clearance takes place quickly, and the plasma LDL cholesterol levels come down quickly with the administration of this drug, bempedoic acid. In fact, bempedoic acid was tried in many subjects in various trials. Clear studies are there, but the clear outcome study is the one that attracts our attention. This was tried in those patients with the statin intolerance or people who were not willing to take statins. One arm received the bempedoic acid, the other arm received only the placebo, which had resulted in the reduction of LDL cholesterol to the extent of 22%. Major adverse cardiovascular event 4 points, reduced by about 13%. There is no increase in diabetes, new onset diabetes. There is no increase in gout in spite of the fact that the uric acid levels by using bempedoic acid had gone up in the long-term follow-up of nearly 40.6 months. Taking evidence into consideration way back 2019, after we published the 2016 recommendation that LDL cholesterol levels in very high-risk individuals should be kept less than 50 milligrams. In 2019, the European Society of Cardiology, in association with the European Atherosclerosis Society, had published this information that people with a very high risk need to keep the levels of LDL cholesterol less than 55 milligrams. For extreme risk group, you need to keep the levels less than 40 milligram. This is the data that was published in 2019. What we did, we published one data in the year 2020. In 2023, we came out a publication which got published in the Journal of Clinical Lipidology. This is about the risk stratification. If you look at the risk stratification, which is to be practiced in our country for Indians, major ASCVD risk factors. One is the age above 45 and 55 in females, current cigarette smoking, high blood pressure, and low HDL cholesterol. These are all coming under major ASCVD risk factors. I will try to concentrate on high risk features because that is interesting for all gastroenterologists. One is the extreme elevation of a single risk factor, family history of premature coronary artery disease, lipoprotein levels more than 50 milligrams, and then the metabolic syndrome, non-alcoholic fatty liver disease with the fibrosis of grade 2 to 3, high risk feature, coronary artery calcium score of more than 99 with less than 75th percentile. 75th percentile. So the risk modifiers I will not dwell. Based on the levels of LDL cholesterol, if it is between 100 to 129, it is LDL, it is low risk. If it is between 130 to 159, it is moderate risk. If it is 160 to 189, it is high risk. And if it is more than 190, it is very high risk. In fact, we introduced this extreme risk group way back 2020, but we have modified it now, taking into consideration if the patient has already developed ASCVD, if he has one more additional high risk feature, probably he comes under category A of extreme risk. And then if he has one very high risk condition, that means in association with the ASCVD established, or a polyvascular disease, or a homozygous familial hypercholesterolemia, he comes under category B. This sort of categorization of A and B in extreme risk warrants our attention because the recommendation from Lipid Association of India is to keep the levels of less than 50 milligram for group A, that is category A, and keep the levels less than 30 milligram for group B or the extreme risk category. We also had introduced group C or the extreme risk category C, where in spite of giving high dose statin, ezetimibe with PCSK9 inhibitor, you have reached the levels of 30 milligrams of LDL cholesterol, but still you have a risk. What are you going to do for this group of patients? For them, probably the levels may be brought down to less than 15 milligrams of LDL cholesterol. So I don't want to dwell into the details of this recommendation. Suffice to say that it is available in the net. You can always repeat.net. If you can browse, you can go through all these publications available for you to go through that, and you can keep such a information on the table so that you can easily categorize your patients under which category this patient is coming, probably under low or moderate risk or a high risk or a very high risk or an extreme risk. What should be the level of LDL cholesterol goal for such type of patients? So the goals have been changed now. Category B requires only less than 30, category A less than 50, very high risk about less than 50. And these are the recommendations given by Lipid Association of India. One should not be surprised that the moment the child is born, it is having only cholesterol, LDL cholesterol of around 30 milligram on up to 70 milligrams are allowed. That's the range what we normally see. So we are fully justified in bringing it to the levels of less than 30 milligram in those people with extreme risk group because of all this information what we had obtained from various trials, various meta-analyses, comparing high dose, moderate dose, including the Mendelian randomization studies, we have come out with this data. So keeping the levels 10 to 15 for C category probably is recommended now and is appearing in this journal also now. In fact, about 10 days back, June 17th, about a week back or so, the Journal of Clinical Lipidology had published this information. Evidence now shows that achieving LDL levels as low as 10 to 40 milligrams per deciliter is safe for patients. You will be worried when you are bringing it down to these levels. Are we going to get into problems? Are we getting serious adverse events? No. Are we getting a serious adverse events for discontinuation of the drugs? No. Is there an elevation of AST, ALT which is alarming? No. CK elevation of more than 5 times the normal? No. Neurocognitive events which are occurring much more? Or it's a fear that has been created in the minds of people who are treating people with statins? No. New onset diabetes, it is not in any way higher when compared to placebo or other groups. Cataract related problems, no. And then any new cancer development, no. Non-cancer, non-cardiovascular death, not increased. What about triglyceride management? I think fibrates are slowly out of the market to introduce to patients for reducing the triglyceride except for familial hypertriglyceridemia. There is a recent study which was published that is called Reduce It trial, which has shown the efficacy of using icosapent ester, 2 grams in the morning, 2 grams in the evening, given to patients with the diabetes, with the established atherosclerotic cardiovascular disease, in whom the LDL cholesterol are less than 70 milligrams, but LDL cholesterol is less than 70 milligrams, but the triglyceride levels are more than 150 milligrams or so, up to 500 milligrams. In those patients, this trial was conducted and came to conclusion the primary endpoint came down by 26% and the secondary endpoints came down by about 25%. Gives a confidence to treat patients with the hypertriglyceridemia, complicating the LDL cholesterol higher values in those patients in whom you are having difficulties in control. This drug probably comes in hand. Familial hypercholesterolemia should not be neglected. If you find one person in the family, you will definitely find many more in the family to have the same problem, because familial hypercholesterolemia is underdiagnosed, undertreated. The lipoprotein little a is not little anymore. It is a small dense LDL particle with an ApoB and ApoA combination, which I don't want to go into the details. I will probably take questions at the end and then try to do that. and the pro-inflammatory, pro-atherogenic, and pro-thrombotic effects. And it has produced a lot of complications. Again, I will probably take questions on this issue. Never forget therapeutic lifestyle changes, Mediterranean diet or the DASH diet. I think this should find a place in patients' waiting room of all our doctors. That's most important to emphasize on the lifestyle modification, particularly the dietary modification. This is about the people who are admitted in ICU for an acute coronary syndrome, how to start the treatment, how to have a follow-up. Very good explanation that has been given, published in the ACCH. Again, only this month it was published. Start with the high dose statin plus ezetimibe. Go for a inclisiran or the drugs like evolocumab. That's the recommendation given by this organization. In spite of all this, ladies and gentlemen, we will probably land up only with a residual risk. Residual risk may be related to lipid, residual risk may be related to the atherosclerotic cardiovascular problems risk. So residual cholesterol risk, residual inflammatory risk, residual thrombotic risk, residual triglyceride risk, residual LPA risk, residual diabetes risk, all those things need to be concentrated if you want to give them a good number of years of life in this beautiful world. So ladies and gentlemen, this is my final slide, which tells you the various information about the various problems that we have seen with respect to the statin trials, ezetimibe, the usage of PCSK9 inhibitors, icosapent ethyl esters usage, and then the bempedoic acid, inclisiran, which are all these drugs are available in our country for us to probably use it in a perfect way to those patients who definitely require this sort of information. I think my final message to those people who are listening to this international webinar is that lower the LDL is better. Lowest is always the best. Earlier the better and longer the better. Only then the people will live for a long, long period in this beautiful world. Thank you very much, Dr. Chandrasekhar. Thank you very much, ladies and gentlemen. Thank you, chairpersons and the panelists.
Thank you, Dr. Natsingan, for a wonderful talk. I would now hand over the mic to Dr. Chandrasekhar. The question answers would be right at the end of the two talks.
I think Dr. Chawla would agree with me, other panelists and the moderator. He studied a lot, all the studies possible in the world. And after studying, he narrated so beautifully.
Yes.
So really amazing that's the reason why he is the vice chairman of Lipid Association of India. And till a week before what happened in yesterday also, 2025, it reminds me of those PGI days. So people come with the question that yesterday there was a release of the press, including the journal has come out the message and just what the message. I think we must congratulate Dr. Narsingan. Big
you, sir.
round of applause and
Thank
fantastic effort you have taken. Very proud that you are in Chennai and you have been wonderful work in the lipid.
Thank you.
I'm very
Thank you.
thankful. And now I call upon, I've already introduced Dr. Gordas Chaudhary. He is the past president of Indian Society of Gastroenterology and he has been the honorary secretary of Indian Society of Gastroenterology. He introduced many innovative programs, including gym and other things. And he is very keen teacher and quite keen observer. And he's got a fantastic the lecturer. And I invite now Dr. Philip Augustine to introduce the topic and invite the speaker. Philip has been already introduced to the audience.
Okay.
Over to Dr. Philip.
Am I audible?
Yeah, you are audible. And
Yeah. Thank you, JC, for inviting me to this beautiful evening program. And, no need to say I've been following your progress and enthusiasm in teaching what you know to the rest of the fraternity, okay? And regarding this fat and liver, the association is known since centuries. Liver has a major role in fat metabolism, and now we know that fat has a major role in liver damage. But now, in 2025, we know much more about the metabolism and the mechanism of liver damage caused by fat, whether it comes from alcohol or from other sources other than alcohol. And Dr. Gauradas Chaudhary, my good friend, it's always a pleasure listening to his talk. And he has great interest in fatty liver disease. So we can expect a thorough discourse of fat and liver today. Dr. Gauradas, please.
Thank you, Philip. Pleasure to see you after a long time.
Thank you.
And Dr. Chandrasekhar, thanks a lot for inviting me to this very august forum. I'll start with my slide presentations, if that's okay with you. Yeah.
Yeah. Yeah. A good GC, it is seen very well.
Is visible? Yeah, good.
Yeah. And
I'm afraid, I must confess to the audience that I'll fall a little short of what Dr. Narasimhan did, because his was a very loaded talk with a lot of information and analysis. Mine, I'll be a little simplistic because I'll talk to you more as a clinician, and I'll tell you how I tend to address this issue of fatty liver disease. So Dr. Chandrasekhar has given a very catchy name, fat and the liver, storage to damage. and, and I think Philip also echoed the same sentiment, that the fat does store, the liver does store fat, but after storing too much of it for too long, damage occurs. And when do we say that now it is causing harm to the liver and to the body? I bring you greetings from my institute, that's the Fortis Memorial Research Institute in Gurgaon. First I'll dive a little bit into a controversy where there are quite a few people amongst our colleagues in India itself. There is a little bit of differences of opinion as to whether the old name was good enough, what we used to call as a non-alcoholic fatty liver disease, or was there a need for a change in name? Many of you are already familiar, but for the sake of repeating to get the clinch some of the important issues. So the NAFLD nomenclature is changing, and it is now called MASLD. MASLD means metabolic dysfunction associated steatotic liver disease. Now, a little bit of a background of what Philip just mentioned. The clinical implications of excess fat in the liver are well known now. Earlier on, people were actually thinking that the main reason why we need to reduce fat from the liver is so that we don't develop liver cirrhosis. Honestly, liver cirrhosis does not occur that commonly. Given the fact that the number of people with extra fat roaming the streets of Chennai are so many, liver cirrhosis occurs only in 20%, and that too only 5% develop decompensated liver cirrhosis, due to which life becomes short. The rest of it is actually, I would take it that fat in the liver is an indicator of something more sinister. So it shortens life, that is, it reduces life expectancy. It actually is associated with a higher frequency of developing type 2 diabetes. It is associated with obesity. Many of us may go into the controversies of whether BMI is a good index of assessing obesity, but that is for another day. Nevertheless, you know how the BMI is classified. So 19 to 25 for the Western world. For the Indians, it is 19 to 23.5. I think Dr. Narasimhan mentioned a very interesting point, that there is increased incidence of cardiovascular or cerebrovascular disease. Very important. Now, he looked at it from the point of view of dyslipidemia. I think the same applies also to patients who have got extra fat in the liver. And liver-related problems, I mentioned to you, it's about 20%. But yes, now with the better control of hepatitis B and C, liver cirrhosis due to fatty liver disease is emerging as an important cause of liver cancer. And it happens over time, and it recedes with sustained effort. Now, this is the important slide which I want you people to focus your minds on. So if you look at patients who have no fat in the liver on this extreme, and people who have a rather aggressive form of fat in the liver called non-alcoholic steatohepatitis. Okay. I'll come to the nomenclature later on. Now you look at life expectancy. So what generally happens is that if there is more fat in the liver, mortality rates go up. So your life expectancy comes down. And if you have a more aggressive form, then the mortality goes up even more. And that is the reason why, if you look at 13 years of follow-up, and people who have extra fat in their liver tend to live shorter lives compared to those of in a similar background but with less or no fat in the liver. Now, why this little bit of a nomenclature change was mooted, the idea? So, it is basically whether you're looking at it only from a liver point of view, which, many hepatologists did. I must confess, I am one of them also, that, we have a tubular vision of looking at only fat in the liver. Actually, now the implications are that after all, fat in the liver is more sinister from many angles. Your cardiovascular disease profile changes, your liver cancer profile changes, your diabetes profile changes. So therefore, people felt that it would be too restrictive to only focus on the liver and look at it in a larger perspective. So I think a couple of years back, there was a meeting of a lot of big bosses from all across the world representing different fora. And we had two people from India as well. And they tried to discuss and thrash out whether there should be a better name than non-alcoholic fatty liver disease. So mind you, non-alcoholic fatty liver disease is actually a non. Non means, you're basically starting with the exclusion clause. It was almost like saying that there was a hepatitis called non-A, non-B hepatitis. Oh, sure enough. I mean, we didn't have tests to diagnose E or C, so we called it non-A, non-B. But the search is on to find a little more clearer etiologic concept. And that's the reason why this non-business was actually, people were a little concerned about it. So this is the consensus nomenclature. So steatotic liver disease is the large all-encompassing term. Steatosis, as you all know, means fat in the liver. Steatotic liver disease. Okay. Now, within this bit, here are the slots. You see, there is on one side, it's called metabolic dysfunction associated steatotic liver disease. Okay. Now, these are people who are typically not taking any alcohol, absolute possible, I would say, teetotalers, maybe a little paunchy, have a lot of these lipids floating around in their blood, the ones which Dr. Narasimhan talked about. They probably have type 2 diabetes. There is often a very strong family history of diabetes, and many of them may have hypertension. So this is a group called MASLD, that is metabolic dysfunction associated steatotic liver disease. From the point of what we generally got to understand in the last 15 years of or 20 years of what is NAFLD, the metabolic parts of it more or less make up this group called MASLD. So metabolic dysfunction associated steatotic liver disease. And within that group, you have an aggressive group where the liver cells are dying very rapidly. So that is called MASH, metabolic dysfunction associated steatohepatitis. So the liver cells are actually dying very frequently with inflammation. Now, a little bit here, there has been a compromise, so it's a bit of a middle playing ground. What do you do in today's society where people do take alcohol? Okay, how much we can discuss later on. But at the same time, they also have all the features of metabolic dysfunction associated steatotic liver disease. So they could be obese, they have hypertension, they have type 2 diabetes, but they do like to party a little bit or maybe meet up with their clients in the restaurant in one of the good hotels in Chennai and have a couple of whiskeys or whatever. So what do you call it? So they're not strictly MASLD because they do take alcohol, yet at the same time, you can't call them alcoholic liver disease because that would be a very severe punitive term for them. And that's the reason why a new term has been coiled. It is called MET-ALD. So there is a metabolic dysfunction and there is alcohol, and the two of them are going hand in hand. Within this group, in this spectrum, there would be one which is more leaning towards the MASLD, where probably the person drinks 2 times a week and 2 pegs a day or whatever, small amounts. On the other hand, there may be one who drinks almost every day 3 pegs, and yet he has all the other things, the paunch, the diabetes, the hypertension, and pop statins. So, this is a little bit of an in-between area. So a broad term would be MET ALD, metabolic dysfunction associated, but at the same time, alcoholic liver disease as well. Then comes the other type that we used to see in Pondicherry when I was there, Jipmer Pondicherry. So, those were the 70s, and there were a lot of people. There was hardly anybody who was very obese, but alcohol was fairly rampant. So every third shop was a alcohol shop. So there were people who were skinny, but they would drink from whenever they woke up all the way till night. And they would actually have alcoholic related liver disease. They did not have metabolic dysfunction, but they actually died of pure alcoholic damage to the liver and alcoholic cirrhosis. Okay, so that's the other extreme. So we are not talking about the paunchy North Indians with diabetes and hypertension. They are the pure alcohol consuming, relatively lean people without metabolic dysfunction. Okay, so this is the way the whole thing has been rolled out. Then there are certain specific etiologies for steatotic liver disease. One of them is actually drug-induced liver injury. Very, very important. I think that people are getting more and more aware about DILI, that is drug-induced liver injury. Monogenic diseases, certain diseases of the lipids and phospholipids and miscellaneous causes. Corticosteroids, for example, or for that matter, amiodarone. Amiodarone, I have seen at least quite a few people getting fatty liver disease due to amiodarone. And it's used by cardiologists because of dysrhythmias or arrhythmias. And that is one of those issues. And then you have a cryptogenic. And cryptogenic should always be included in any nomenclature spectrum because, there are some in which you just don't know the cause, but they do have fatty liver disease. So this is what we have at this point in time by way of the new nomenclature, the consensus nomenclature. I took a little more time on this slide, but this is what the cardiometabolic criteria are now. So in order to make sure that you fit in or squeezed in into one of these compartments, they have put out the metabolic or cardiometabolic criteria. So any one out of the 5, if it is so, it qualifies for the M part of it, the metabolic dysfunction associated. So a BMI of 25, now mind you, this is the Western one. So for India, it would be 23 for Asians. Or you look at ethnicity adjusted equivalent of that if you have one. I think many people vouch that the abdominal girth and the waist hip circumference may be a better indicator. If your fasting glucose is a little more than 100 milligrams, or a 2-hour PP is somewhat elevated, more than 140, or a HbA1c more than 5.7, or a treatment of type 2 diabetes is already on. Now, the criteria, as you can make out, are a little too stringent. I mean, you have to be really fit and to want to be a centenarian, but nevertheless, these are the criteria which have been proposed. If your blood pressure levels hovered above 130/85, or if you're on a specific antihypertensive drug. Now coming to the part that Dr. Narasimhan so well dealt with, if your plasma triglycerides are high, more than 150, and this is a very important part, that most Asians tend to have a high triglyceride levels. I was listening very intently to Dr. Narasimhan's figures, and he said that the triglyceride elevations are much more in his population that he studies than the cholesterol ones. And it reflects very truly on what we actually see on the ground. And if your plasma HDL cholesterol is a bit low, and he went to explaining as to why the HDL is so important and triglycerides need to be kept low. The pediatric criteria are there as well, any one of the 5. I won't go into the details, but nevertheless, fairly stringent criteria. But why the pediatric criteria are important is because today we see a huge amount of increase or elevation in pediatric overweight and obesity, because I think that we are probably eating far more ice creams and burgers or whatever it is. And that's the reason why pediatric MASLD is also becoming a problem to reckon with. So what is the decision support tool? So if you find fat in the liver, you don't have to do a liver biopsy. Even if an ultrasound says there is fat in the liver, it's good enough. If you want to do any of the other tests, the non-invasive tests, they're good enough. So if you have extra fat in your liver, the question to be asked is that does this patient meet any of the cardiometabolic criteria? If he does, then he goes into this compartment, the metabolic part, dysfunction part, and then you ask how much is your alcohol consumption. If it is significant, then you call it MET ALD. If there is none or very little, then it is only a pure metabolic dysfunction associated steatotic liver disease. So this is a fairly simple one. And I think that the whole situation is getting a little crowded, because in my days in JIPMER, I remember either it was a complete teetotaler or it was one who would actually have it rather frequently. Now you have quite a bit in the middle. Now, if your cardiometabolic criteria are negative, then either you could be tempted to call it cryptogenic right in the beginning if there are no other causes. But if you explore a little bit, you might find out other causes. For example, autoimmune liver disease, drug-induced liver disease, monogenic diseases, and that is actually one of those areas which should tickle your brain. Now, after this, I think I'll go a little bit into the treatment pyramid. Needless to say that the main bottom line, or shall we say the base of the treatment pyramid, should be diet, lifestyle, and weight reduction. So that is lifestyle changes. And let me qualify why. So there was a time, I guess about 4 generations before, when people used to till the field and they used to eat a lot of whole grains and stuff like that, and they used to walk a lot. Fatty liver was not such an important issue. Now, in India as well as in many parts of the world, particularly in India, the genetic pool within community tends to remain the same. For example, you would have a person from Tamil Nadu from a particular caste usually marrying within that same system, the same group. So the genetic pool could not have changed. So if there has been a change in the phenotype, it has obviously occurred because of something else, and that is the lifestyle and the environment. Okay, so diet and lifestyle correction remains at the core, and then we will work ourselves up as to what are the therapies which are available. So first, let me draw your attention to diet, lifestyle, and weight reduction. These are the keys. So I think that, we come to the drugs later, but the most important is how to convince a patient to eat healthy and exercise and to be able to maintain or lower the excess weight, shed the excess weight, and feel fit. So we did a small little experiment in my days when I was in Lucknow. All these people, you can see they have a little paunch, and they were people from the administrative block. And we used to invite them, they had all fatty liver disease, for an aerobic exercise session, for which we had called very well-trained trainers, and we put them on a diet as well. So it was a calorie-restricted diet with exercise, and they were encouraged to lose weight. I won't go into the details of the study, but nevertheless, we found, like in any population, there were some people who followed it very well, lost weight, and improved. So in them, the liver enzymes actually came down, the elevated liver enzymes. Okay. And then there were few who did not do it, but we maintained telephonic contact and found out, are you still there? How is your liver functions? Come over and get it done. And we found that there were no changes in the liver functions. So this paper was published long time back. I think it was in 2006 or something, which was it was in an international journal, to prove the point that diet and lifestyle change can bring down elevated liver enzymes in patients with fatty liver disease. Okay. And non-compliant people did not achieve it. I'm once again going into it in this era where so many fancy medicines are available, to drive home the point that actually improvement can occur if you are able to convince your patient to live a healthy life. So we went a little further with all this diet and exercise and so on. And one of the reviews that came back for our second paper was, you showed improvement in liver enzymes, but what happened to the fat in the liver? So by that time, we had quite a few patients, 60 odd. And in some of them who had shown remarkable improvement, we requested if we could do what is called as a paired biopsy. A paired biopsy means the first biopsy done when he joined the program. Everybody who joined the program did not necessarily have to have a liver biopsy, but almost 50% had. And some of them who improved, we asked them that, would you mind getting another one done? And many said yes. So we had paired biopsy in quite a few patients. Now you can see this shows the fat droplets inside the hepatocytes. And you see, after a successful completion of 6 months, the fat had disappeared. And this is the same patient. It's called a paired biopsy. Just to take you one step back, Dr. Chandrasekhar wanted me to talk about how is fat stored. And you know, the commonest way in which fat is stored in hepatocytes is as triglycerides. So these are all triglycerides, okay? And then when you actually burn triglycerides or you reduce their formation in the liver, then the fat disappears and you get a nice healthy liver, okay? So this paper was, to my mind, one of my very important papers. It was published in 2012, where we actually showed that lifestyle modification improved insulin resistance and liver histology in patients with non-alcoholic fatty liver disease. There was another slide, I probably forgot to include it here. This was on HOMA scores, the insulin scores, you know, the HOMA levels, and the people who improved, their HOMA scores came down. So it actually clinched the issue that the mobilization and reduction of fat was related to increased insulin sensitivity, or you know how the insulin metabolism worked. Now, we all know that whenever you ask people to do exercise and follow a diet, many people feel you're wasting your time, because ultimately that is one thing which people would hear from one ear and then throw it out from the other. So medications have found their way. And you know, most doctors feel that unless you have written a prescription, you're not a doctor anymore. So that's the reason why medical therapies have come in, and it is there to stay. So let me see what is there that we should all take home. So this is the treatment pyramid, which I showed you a little while earlier. So if it is a person who is willing to try a little bit of lifestyle changes, his liver enzymes are just a little elevated, you know, and he doesn't have any other major risk factors. He might be a diabetic, you know, maybe taking metformin or hypertensive. Then the first line medical therapies would be either vitamin E or pioglitazone or saroglitazar. All three are reasonably safe. And you know, they're fairly safe for even for periods of 2 to 5 years. Pioglitazone is, as you know, it's a insulin sensitizer. I somehow don't like pioglitazone much for the simple reason that 40% of people on pio actually put on weight. And if they're already overweight to start with, things get a little more clumsy. Vitamin E, it came out in the PIVENS trial long time back, has been found to be useful. And they normally recommend 400 milligrams twice a day. If I remember right, it was 800 milligrams more than that. We, of course, use it in a slightly lower dose. And saroglitazar is one of the Indian-made drugs, which is an alpha-gamma PPAR agonist, which has been found to be pretty good in India. Saroglitazar, by the way, started its journey more as a agent for diabetic dyslipidemia. And therefore, Dr. Narasimhan would be more familiar with it. But it found its way into diabetic fatty liver disease, and now even for non-diabetic fatty liver disease of the MASL variety, that is the metabolic dysfunction associated liver disease part of it, steatotic liver disease. So that is what we have to offer. So here are the data. So saroglitazar is a PPAR alpha gamma agonist. It's been found to be useful. One of its virtues, if you might like to call it, is that it brings down the liver enzymes quickly. It reduces triglycerides well, and it's fairly safe. I mean, the amount of prescriptions which I guess people all around the country are writing, it is fairly enormous and not very, I mean, fairly devoid of major side effects. On the other hand, the limitations are that very well-powered, vast, elaborate clinical trials are not as many as one would have liked, and therefore the Western world hasn't yet embraced it so lovingly as of now. But I think that is what we have at this point in time. It's not a bad drug at all. Now we go up a little bit more, and as we mentioned, that patients who have metabolic dysfunction associated steatotic liver disease usually often have diabetes or they are pre-diabetic. And one of the, in fact, this is the area where our diabetologist and us, we often interact quite a bit because the same agents which they use, we also use, and they seem to be giving good results. So one of the medicines which is now fairly common in the Indian market, and I believe the prices have also been brought down, is the SGL2 inhibitors, oral tablets, and like dapagliflozin and so on and so forth. So these studies initially done for diabetic control, this is they produce glycosuria. Therefore, the peak levels of the glucose in the blood, they actually get blunted. But these medicines have been pretty good for reducing fat in the liver. In my experience, a lot of these patients also significantly show significant weight loss and mobilization of fat. One of the advantages of an SGL2 inhibitor is that it does not normally produce hypoglycemia. So therefore, it doesn't need to be prescribed all the time only by a diabetologist. I'm sure they prescribe it much more than us. But also I was surprised that SGL2 inhibitors are now being widely used by cardiologists because they have found that it's supposed to help in congestive cardiac failure. And again, the safety comes in because they don't produce hypoglycemia. So the relative comfort and ease with which they can be prescribed seems to be to their advantage. Let me see the data. Yeah, so if you see the SGL2 inhibitors in diabetic MASLD, you find that there has been fairly impressive decline in the fat, but there is also simultaneous improvement in the diabetic status. Empagliflozin is the one which was studied in the ELIF study, and the lead study, of course, used another one. So needless to say that this group of medicines is good. So what I do now, when I get a diabetic who is obese and he's on metformin and glimepiride or one of the sulfonylureas, I usually write a small little note to the diabetologist requesting that, do you mind trying to change your sulfonylureas to something else, the SGL2s. And everybody obviously likes to have it their own way, but most diabetologists who listen and change, I find that with one stone you can hit two birds kind of a story. So their fatty liver also improves, so does the diabetes. Now we come to a group of medicines which I showed in the previous chart. It is called semaglutide. Now, semaglutide again is a medicine which is a glucagon-like peptide GLP-1 analog, and it actually came in the arena of diabetes. It was an anti-diabetic. Very soon, people realized that people who were on semaglutide, injectable to start with, they showed significant improvement in liver functions, okay, and they also lost weight. Now imagine, bingo, all three together, diabetes getting better, the weight coming down in a person who's obese, and the liver enzymes normalizing. So this caught the fancy, and it's now prescribed very frequently all over the world, both injectable and now it's also in an oral form. There is a little controversy raging as to the efficacy of semaglutide in reducing liver fat in the oral form, and whether it's the weekly injectable form which should be preferred. But nevertheless, this medicine has come to stay, and obviously a lot of people are using it. I was at a meeting with Dr. Nageshwar Reddy recently, and he said that every other person in his practice in Hyderabad is popping this oral ribelsis, to the extent that he puts in the scope in a person who's 8-hour or 12-hour fasting, and he finds that there is gastroparesis, food in the stomach. So all that you have to do is ask them, are you taking a pill which you didn't tell me? And they would say, yes, we are on semaglutide oral tablets. So one of the major problems is gastroparesis. It slows down the intestinal mobility. It has quite a few other, shall we say, adverse effects. The appetite does come down. It has also some side effects, especially with the thyroid and so on and so forth. But nevertheless, it's also got an advantage that, like semaglutide, it doesn't cause very profound episodes of hypoglycemia. And that's why people are not too scared to use it. I mean, at best, what happens is if the person's appetite goes for a toss and he's very uncomfortable, you have to stop it. So this is the medicine which is now becoming very popular. And of course, now other medicines are coming up as well. So randomized clinical trial of semaglutide versus placebo reduced liver steatosis. It did not reduce liver stiffness, though, in those such studies. And that has become the hot topic for yet another group of chemical compounds, which we'll talk about. So in subjects with non-alcoholic fatty liver disease assessed by magnetic resonance imaging. Quite an old article published 2021, and now there are several more. Now, GLP-1A and other combined agents. So I'll come back to this a little bit, but here we are. These have now become more popular. Apart from being anti-diabetic drugs, they're also weight-reducing drugs. So the fatty liver part has gone into the background, but anyway, let it not be a matter of ego. The fact is, if the weight comes down and if your sugar control gets better and your liver fat also comes down, nothing like it. So I think that quite a few of these agents are here. Some are primarily causing weight reduction. For that matter, orlistat, they've also been shown to be somewhat better by losing weight. But there are other glutides, I just mentioned semaglutide. So you have liraglutide and so on and so forth. So quite a few of them. And weight loss drugs in the near future. So there are most of them, if you're able to lose weight, you're also able to help your liver. For that matter, the most impressive studies are ones with bariatric surgery. So people with a BMI of 40 who have a lot of fat in their liver, once they undergo a bariatric surgery and they drop 20 kgs in a year, their liver fat goes for a toss. I mean, it really comes down. And I think that's one of the most compelling evidences that we have, is that fat reduction or reduction of weight can lead to improvement in fatty liver disease. So now semaglutide, one is trying to kind of get past it with a more effective compound. I think all of you are aware of the fact that tirzepatide is the new molecule. It by and large comes as injections, and it has now come into India. And therefore, a lot of people, especially our endocrinologists, weight management people, diabetol, I mean, a lot of them, they're using Mounjaro. Mounjaro is a GLP-1 and a GIP agonist. So it works on two receptors. The mechanism of action is in some way similar, that it reduces appetite. It does cause some degree of gastroparesis. It causes weight reduction. And along with that, improvement in liver enzymes and mobilization of fat from the liver. Okay? So I'm sure many of you would have tried it, and probably you have your results or opinions to share. It's a weekly injection, by the way, and it comes in strengths of 2.5, 5, 7.5 and 10, and thereafter you can go up a little bit more. But these are weekly injections, and you have to see how much your patient is able to tolerate and what's the kind of rate of benefit that you're trying to achieve. So after this, what are we left with? So one of the problems that we see in India is that many patients, by the time they come to us, they already have significant liver fibrosis. Now, one way of looking at it is that if the liver functions are okay, there is not much of a portal hypertension. So if you can bring down his weight and mobilize his fat, we presume that the progression of liver disease would slow down. And to an extent it does. In many of my patients on follow-up, I see that. However, if you have to do studies and look at biopsy-proven reversal of fibrosis, most of these drugs have not shown to be very good at that. So it would reduce inflammation, that would reduce stiffness, it would reduce some degree of fat to the extent that, some of your liver fibroscan measurements would improve. But can you actually reverse F4 fibrosis? Or, can you bring back a cirrhotic liver to a totally non-cirrhotic F2 stage? That seems a little difficult, although occasional anecdotal reports are there. And that's the reason why yet another drug has recently come into the market. This drug is called resmetirom. This has got a completely unique way of action. It's been found that there are thyroid hormone receptors within the hepatocytes. And if you can stimulate or activate these thyroid hormone receptors, the beta type, they tend to actually burn up the fat which is stored in the hepatocyte. So that's the mechanism by which Resdifra works. This is called resmetirom. To the best of my knowledge, it comes in 80 and 100 milligrams, but there could be yet another type of a packaging. The method of giving is simple. It's an oral medicine. And this has been fast-tracked by the FDA and given an approval very recently. The initial problem that I had when I talked to my American friends was that it was prohibitively expensive. And probably we Indians do some things better than many others. So now it is available in India by at least 3 Indian companies, and the prices have actually come down. I can't claim that I have too much of an experience with it, but anybody with a weight of above 100 kg, it's 1 tablet, 100 milligrams daily in the morning. And anybody below 100 kg, it's 80 milligrams 1 daily in the morning. The prices are affordable. Actually, 1 box of 30 is costing, well, when I say affordable, don't jump at me. I heard today that it's about 24,000 rupees. Now, 24 is, of course, neither here nor there. For people in Chennai, it's minuscule. For people in my part of the country, like Lucknow, it's pretty heavy. But nevertheless, I must tell you that this is the kind of a product which is there. As time evolves, we will see more and more as to how it is benefiting and how is the clinical response. So this is what I had to tell you. And at the end of it, I would say that fatty liver disease is today occupying a good bit of our mental and clinical space. Dr. Philip would be, confirming it. He was one of the persons who first offered me a job when I had passed out from All India Institute. And that was in Kutatukula.
Right, right.
Yeah. And I remember that time in hepatology, we were obsessed with only hepatitis B. That time, hepatitis C was not discovered. Okay. And then there was a time when we were obsessed with treating hepatitis B, and then came C. And now today, you ask any hepatologist, including Dr. Philip's son, Abby. So it's either alcohol or fatty liver disease. Okay. And that is what is actually over time. So do the best you can until you know better. When you know better, do that. So that is one of the beautiful sayings that I heard from Maya Angelou. I think, until you know better, there is a K missing in the second line. And I think that anything in science is only a transition. So it depends on where you find yourself at which point in time. I don't think that we should laugh at anything, because as they say, the wisdom of one generation is the folly of the next. So tomorrow what will happen would be probably a game changer. So with that, let me once again thank my 2 hosts, Dr. Chandrasekhar, the ever smiling, beaming, pleasant Dr. Chandrasekhar, and of course, almost like my mentor, Dr. Philip, and Dr. Narasimhan. I really enjoyed your talk. Thank you so much.
Well, thank you, Gauradas. As expected, very concise and comprehensive talk. I'm sure there will be a lot of questions and opinions. So we straight away go on to the question answer session. Dr. Chandrasekhar?
Yeah, I think Gaurav sir, you did a fantastic job. I like the last slide, including that. And you said Rasmitrom, but you always felt that Chennai is richer than Lucknow. So I understand that.
Chandrasekhar, there is no doubt seeing you and VG Mohan Prasad. Come on here.
Okay, right? So you stop sharing now, then we will go to
Yeah.
the. So, yeah.
Sorry.
Thank you very much, GC. You, as usual, you did a fantastic job. And Naran Singhan was full of studies and he studied so much. And you made a very practical approach to and a storage to damage, how we can prevent it. And now the format is like that. We'll start with the first question from Dr. Chawla. Then second will be Dr. Philip and three panelists. We will have a 3 rounds of talk. So I request all of you to be very brief to the in the question and answers equally brief.
Did you have some
Let me start
questions
with
from the
Dr.
audience?
Chawla.
Did you have
Yeah.
some questions from the audience?
Yeah, we have some question, but whatever has come earlier, we'll take up first.
Yeah.
The first question, I will start set the ball rolling. How do you increase HDL cholesterol? Is there any drug available or apart from exercise, is there any way? After that, Dr. Chawla will be asking the question.
See, the initial studies which were actually focusing attention mainly to increase the HDL cholesterol had failed to show any sort of benefit. For example, the nicotinic acid which was used in studies, many studies did not show any sort of improvement. The cholesterol ester transfer protein inhibitors, CETP inhibitors, particularly the torcetrapib, anacetrapib, dalcetrapib, all those drugs did not show any sort of cardiovascular benefit, in spite of the fact that many of them were showing increase in the HDL cholesterol to the extent of 80, 90 milligrams, 100 milligrams. Currently, we don't have any weapon to tackle an increase in the HDL cholesterol, which we wanted. But as such, we cannot do, for example, we cannot advise any of the therapy except the obicetrapib, which I was mentioning. Obicetrapib is again a CETP inhibitor, which has shown some increase in the HDL. At the same time, LDL is also reduced. The long-term data is not available. We need to wait for some more time. Till that time, the best way to advise our patients is to go for lifestyle modification, particularly the exercise. Very vigorous exercise only can increase the cholesterol, but one cannot advise vigorous exercise all through for our patients. We should tell them to have a continuous uninterrupted exercise at least 5 days a week or 6 days a week. That probably in the long run will help him to increase HDL.
Thank you. Dr. Chawla, please.
Yeah. The audience would like to know what is the ideal target lipid values in the primary prevention of cardiovascular disease. You've mentioned significantly about the LDL levels,
Yeah.
but what should be the target lipid values of LDL, HDL, and triglycerides? Just a revision for everyone.
Yeah, I think the best thing is to advise our patients or people who don't have disease seeking care for primary prevention. You need to advise them to bring down the LDL cholesterol less than 100. HDL should be more than 40 in a male, and in females it should be more than 50. For the triglyceride, it should be less than 150 in the fasting state, and in the non-fasting state, it can be up to 175. So it should be less than 175 in the non-fasting state. It should be less than 150 in the fasting state as far as the triglyceride is concerned. Whereas for HDL, it is 40 for men and more than 50 for women. For LDL, it should be less than 100.
Should the sampling be done in a fasting state or a non-fasting state?
Traditionally, we were all following only the practice of submitting our patients for a fasting state of lipid profile. I think that should be discarded. There is no need to allow our patients to go in the fasting state. Non-fasting samples are excellent samples which will not differ in any way except for the mild increase in the triglyceride. The triglyceride goes up by only 26 milligram in a huge study conducted in about 1.5 lakh patients in the United States, clearly shown that 26 milligram increase in the triglyceride in the non-fasting state, which is not significant. So one can allow our patients to go for a non-fasting. Non-fasting is simple for patients, simple for clinicians, simple for laboratory people to do that. I think many studies which we had taken into consideration for our evidence, all the studies have shown only non-fasting lipid profile estimation and not fasting. Fasting is required only for those people who are recovering from hypertriglyceridemia, number one, or people with the pancreatitis. Probably they may require a fasting sample. Or in patients with diabetes, when you're sending the patient for a fasting blood sugar, I think it is mandatory to combine it and then ask them to go for a lipid profile.
Thank you.
Dr. Philip to GC.
Yeah, can I ask one question to Professor Narasimhan?
Yeah.
So we
Dr.
didn't
Narasimhan.
hear, you didn't mention anything about fenofibrate. Is that out of the treatment armamentarium?
Yeah, it's a good question, sir. Fibrates, actually, we had been having this molecule for the past 5 decades with no benefit in cardiovascular outcome till today. The studies which were conducted using fenofibrate was particularly a ACCORD study, which has shown no benefit at all in those people with the diabetes. The number of studies which were conducted with using pisafibrate and the other drugs also did not show benefits. If you group all these studies and do a meta-analysis, it looks as though there's going to be benefit for those people above 204 milligrams of triglyceride. There is some benefit of reduction of cardiovascular risk, but however, it is not routinely recommended to be combined with the statin. As such, there is no recommendation except for those patients in whom you have triglyceride level more than 500 milligram.
Thank you.
Philip.
Yeah. Um,
While you are preparing the question to Dr. GC, I have a question that somebody has said. You said the last molecule resveratrol. They act through the thyroid stimulation of the fat. Do they have system effects on hyperthyroidism like that? How do they selectively go and act it? That's the question.
What I understood from the literature, let me tell you, I don't have personal experience, that it doesn't have. It actually works intrahepatic, intracellular, and therefore it's the receptor agonist of the thyroid hormone, and therefore it does not have the metabolic factors which thyroid hormone has, where your heart rate goes up and so on and so forth. So it's specific to the liver.
Specific to the liver. Okay. Dr. Chaubal?
I have two questions to ask from Dr. Gauradas Chaudhary. First is, do you recommend weight loss in a patient who have lean mass? If so, how much? The second question, which has always been plaguing me, is if you look at the incidence of hepatocellular cancer in these patients, almost 35% of these patients develop this malignancy in a non-cirrhotic liver. For cirrhosis liver, you have definite surveillance guidelines that you have to do, say, ultrasound or this thing at certain intervals. We do not have a guideline for these situations. Do we have any biomarkers which are in the pipeline to solve this particular dilemma?
So I'll start with your first question. Very important question. I think this is an important question for India, what we call as lean NAFLD. Okay. So actually the lean NAFLD is really not lean NAFLD. In fact, we have published on that. What we found is that when you take lean, meaning that they are within the normal Western BMI range, that is 19 to 25. So that means they are not obese by Western standards. They were often included in the group of lean NAFLD. We did HOMA studies in them, and what we found is that their HOMA scores were slightly higher than the ones who did not have fat. Now, here what happens is that weight loss is not the target. It is basically redistribution of body mass. So if they actually do exercise and a combination, see those days, in 2006, we were doing aerobic exercise. Now there is enough evidence to say that it should be a combination of aerobic and strength training exercise. So if you build your muscle mass, therefore the fat gets converted to muscle, And therefore, your lean NASH, the weight does not change, but your metabolic profile changes and the fat gets mobilized from the liver. So, in terms of the etiopathogenesis, it's similar, except that the word lean is actually a misnomer. So, this is what we have reported also, and that's been my experience. With regard to the second question that you asked, there has been a lot of literature going around, and fortunately, I was never one of those literature guys. I like to have my feet on the ground. So, if you see the amount of fatty liver disease going around of lean people without cirrhosis, those figures of 30% HCC, I just wanted to ask my august, co-chairs, do you really see that? I mean, at least I don't. And I'll tell you why. There was a time when we thought they occur, and it was blamed on aflatoxins and so many other things, latent hepatitis B and so on and so forth. But to be honest, I'm not really seeing much of it occurring in non-cirrhotic livers in non-obese people. When it occurs, it's usually in cirrhotic people. At least that's the kind of experience I'm having in the northern part of the country. I've traveled all over the country, so I know the nuances and differences between east, now north and south. So what I'm talking about, the north may absolutely not match what you see in the south, but at least in the north, I don't seem to see it either in Lucknow or in Delhi. So I think those figures are either, like whenever you give a PhD thesis or a research topic to a young resident, he will go around hunting it and he'll spot a lot many cases than actually occurs. So that may not really be happening on the real life world. That's my feeling.
I think I'll agree with you, Gaurav. I do agree with you.
You
Can I
agree
ask
that
Even I
HCC
agree.
is not common in the mast liver?
No, I
No.
said it is certainly seen in liver. Okay, let me put things in perspective. The incidence of HCC in muscle liver is slightly less than what it used to be for hepatitis C and hepatitis B. I'm talking about the risk factor. Okay. The question is that yes, it does happen. So it becomes the fourth cause of liver cancer after hepatitis C, B, alcohol and fatty liver disease, non-alcoholic fatty liver disease. The problem is that when it occurs in a background of MASLD, it tends to be much more difficult to manage. Because, with all the metabolic factors going in disarray, so that even liver transplant outcomes are pretty bad in patients who have got MASLD cirrhosis compared to a person who has got hepatitis B related cirrhosis.
Because
So
of
it does
comorbidity,
occur, but a little lesser incidence according to you.
I
Okay.
mean, what I feel is that the fear is more that if you develop it, yes, the dangers are much more given your background problem, starting from liver transplant.
But sometimes we do see cases where totally asymptomatic and
Yeah, it does
very
happen.
obese, and you do the screening just for the pain and huge hepatocellular carcinoma, and all
what
other
I'm saying.
factors are rolled. That is the one
That is
worrisome.
what I'm saying.
That is the
But
one
there's also
worrisome
the
to us.
incidence of
Yeah.
also
And
the
Dr.
incidence of
Narasimhan will
HCC is
be.
less, but
Dr.
still, what I'm trying to say,
Yeah,
just a
I
minute.
understand.
What
And
I'm trying to say actually is, in all hepatitis B and C, most of the HCC occurs in a cirrhotic liver. But in the MASLD and these problems, whatever the incidence of HCC may be in this particular condition, but definitely I think the literature says around 30% times, if the HCC is occurring, it usually occurs in a non-cirrhotic MASLD. So
Okay.
that's the situation there. That's what is worrying actually.
That probably is not right, Chawal. The
But
literature
this is what the
says,
literature mentions. The APSL
yeah,
guidelines.
that's right. The cases that we see are usually cirrhotic.
That's what I'm saying.
Very few of them are non-cirrhotic, massive.
Okay,
But
Dr.
even the
Praveen Kumar.
APSL guideline, which came in 2023, also mentions about the same incidence.
Yeah.
Actually.
Okay.
Yeah.
Dr. Praveen, please.
Yeah.
You have a question?
My question is to Professor Narasimhan. A question received from the audience. Which patients require more aggressive lipid lowering, even if the LDL is in the borderline category?
One thing that I would like to say, patients admitted for acute coronary syndrome,
Yes, sir.
whether it is STEMI or NSTMI, or those patients with a chronic stable angina getting into complications, I think all of them should receive high dose statin, irrespective of the levels of LDL cholesterol. Many times we see such patients only in ICU. Most of the time, the people will come out and say there is no LDL cholesterol also increase. What is the exact cause and all? I think one need not get worried about the LDL levels. Draw the blood, send it for analysis, straight away put the patient on high dose statin, irrespective of the levels of LDL cholesterol. That's number one. Number two, patients with diabetes, when they have a higher risk, they are all at a high risk only. People with the diabetes are at a higher risk. So their LDL levels probably may be normal or may be below normal or slightly increased. That's all. If there is a hyperglycemia which is uncontrolled in type 1 diabetes, the triglyceride levels go up. In type 2 diabetes, the LDL levels go up to some extent. That's all. So most of them will have either normal levels or below normal levels. So
So, yes.
irrespective of the levels of LDL cholesterol, people with the diabetes
Yes,
are
sir.
all at a high risk. They need to receive moderate dose statin or high dose statin. Moderate dose statin is required only for those patients in whom you don't have any other risk factor. Most of them will have comorbid conditions like hypertension and then the dyslipidemia plus smoking problems, all those things. If your combined problems are encountered, one has to put the patient on high dose statin. And
Thank
then
you.
other one is the familial hypercholesterolemia, where the LDL cholesterol is very high. You need to start the patient on high dose statin.
Okay, now we will move on
Yes.
to the rapid fire. So we have to be a little faster in the question and answer. Dr. Ashish, you have to unmute yourself first. Okay, Ashish. Okay.
Yes, sir.
Your question too?
Sir, my question to Dr. Narasimhan, what is the effect of statins on muscular pain or atrophy or so for long-standing statins?
Yeah. Whenever we start statin, normally we encounter problems of myalgia. So that has been actually every time people know when they receive this drug, they always have an inhibition to get it started, or they try to consult other people. Then they Google it and then look at myalgia. They come back and tell us also that there's going to be a problem. Are you very strict, sir, in allowing me to take this drug? Do you think that it is really required? My idea is to educate the patient properly, tell him that this is required, beneficial effects are much more than the harmful effects. Most of them will come back only with a small problem of pain in the muscles. Normally, I tell my patient that the pain will occur in the muscles. It does not mean that you are developing severe problems. In case it becomes severe, you come and report to me. Otherwise, there is no need to come and see me. Because it can be a simple myalgia, or it can be myositis, or it can be myonecrosis, or it can be rhabdomyolysis. So rhabdomyolysis is a life-threatening problem where the renal failure also occurs. Whereas these patients who require this sort of so-called myalgia when they seek advice, try to do the CPK. If it is less than around 4 or less than 4, allow them to continue the drugs under your medical supervision. There is no need to stop. If it is between 4 and 10 of 5 times 4 times upper limit of normal, up to 10 times upper limit of normal, between these two categories, probably these patients need to be advised to stop the drug. At the end of 2 weeks, again, reassess the entire problem, explain to the patient the necessity of restarting the drug, how to start, go for a newer drug. For example, if you have started rosuvastatin, go for other atorvastatin, other drug, or give a smaller dose. Again, increase the dose. So you can de-escalate, increase the dose, or you can change over, or you can give the patient on alternate day, or weekly twice, or weekly thrice. It can be done.
So you
that's
do the enzyme level or alter the dose or change the molecule.
if it is more than 10 times the upper limit of normal, you have to stop the drug.
Yeah,
Consult
this
with a
was-
nephrologist.
We are moving to the second round of the discussion, starting with Dr. Chawla. Any burning question you have?
Yeah. Because, during your talk, Dr. Narasimhan, you mentioned about high intensity and moderate intensity statins. What is the definition of moderate and high? And how do you categorize atorvastatin versus rosuvastatin? And how often would one like to add the second line drug as estimate? I can't pronounce it, but the
Pembedekas.
yeah.
Sir, this moderate
Want a
statin.
brief answer so that we'll take
Yeah.
up more questions. Thank you.
Yes, sir. Yes, sir. the moderate dose statin and all, no, depending on the statin, what you are going to use. The most powerful statin is rosuvastatin. 20 milligram of rosuvastatin is equal to 40 milligram of atorvastatin. If you are going to give 40 milligram of rosuva, that means it's 80 milligram of atorvastatin. These are the two drugs which are available in our country in plenty, so we can always use it. Moderate dose statin means it must be around 20 milligram of atorvastatin or 10 milligram of rosuvastatin. If you are going for 20 milligram of atorva and then the 20 milligram of rosuvastatin or 40 milligram of rosuva, it is high dose. 20
Right.
milligram and 40 milligram of rosuva, high dose. 10 milligram is moderate dose. Like that, no, you need to classify. The potent statin is only rosuvastatin.
Okay.
When do you want to use ezetimibe? I have clearly mentioned in my lecture also saying that
We'll
it
look
is a
into
drug
the
of choice.
slide and we'll decide that.
The LDL levels. Okay.
Okay, question to Dr. GC. What is your preferred choice, fibroscan versus elastogram? Share wave.
Actually, to be honest, it depends on what you have readily available. I think that
Okay.
we have a fibroscan with a cap. I find it useful. But having said that, I don't want to tom-tom for one particular test alone. If you do that repeatedly and, on this, on 2 consecutive days by 2 different technicians, you will find variations. So it is called inter-observer variation. So if the variation is in a normal range, which doesn't matter, for example, your E score, LSM score is in the range of 6 or 5. How does it matter? And CAP score may move from say about 280 to 295. It doesn't matter. But overall, what I find is that in a person, if you need to know, is there a significant increase in stiffness where your management will change? For example, if I find a fibroscan score which is showing 15, the platelets are low, the albumin is 3 or 3.2, I know that I'm talking about liver cirrhosis. So, I mean, I would look at it in a larger context rather than only on one score. One score is terribly fallacious. I mean, I've had patients, who have had their probe touching a rib and, the E score has been pretty high. So we all know that these things
So
happen.
you will take up overall the.
So in clinical trials where it is very important to measure small changes, people have started preferring magnetic resonance imaging. But that is expensive and time consuming. So these are actually for day-to-day clinical tools, the one which you have readily available. And if you have more or less come to understand which technician gives you more predictable results, I'm quite happy with that.
Dr. Philip, your question to.
Yeah, Gaudas, see, there is an increasing demand and temptation to start semaglutide in patients without diabetes, with NASH in Kerala. What is your take on that?
Difficult question. See, from one point of view, it's people who cosmetically want to reduce weight. What are their choices? Once upon a time, they would go in for a bariatric surgery. Now, suddenly, bariatric surgery has not been in favor for a while.
Right.
Gastric balloon and gastric procedures, they came with a lot of hullabaloo, but they never really stayed there. I mean, people felt a little discouraged. So now people are actually in the mood of trying this or that, and with the huge amount of publicity. So I see a lot of patients taking Mounjaro injections or semaglutide. The problem also is that most of them, they try for a little while and they don't continue to a desired end. But the side effects sometimes are such that they come to agree that, okay, let me remain the way I am. So that's the way things are happening on the market as of now. I'm sure Kerala is a very educated group of people, so I wouldn't be surprised if people take it there.
Yeah, but our endocrinologists never agree, so
I
far.
think I agree with GC. There is a lot of hype with the Mounjaro, and some of the really high class, the upper crust and the who can afford, they are now getting the medicines from the Gulf countries and started trying. They come and ask me whether already after trying that they come and ask me, can we go ahead with that and all. So I think a lot of we need to go more about all these newer pharmaceutical agents before we recommend them. So I think we have 6 minutes to go. Now the time for me to ask you to know more about our faculty that will inspire our delegates from all over the world. Now the question I'm going to ask is, what is the last lifestyle modification you did yesterday or in a week time? We'll start with Chaubal. While he's thinking, Dr. Chawla, you have been avid about the lifestyle modification. Okay, I've been doing for last 10 years, doing in 5 years, or I only preach and I'm very healthy.
I'm taking care of my diet now, trying to avoid saturated and trans fats in my diet, calorie restriction, and try to do some exercise.
Okay, diet, I agree with you. Okay, now GC.
So I'm also actually become a little careful with what I eat. So I'm off sugars. I'm generally not too much into fast food. I do have a drink once in a while, but that is not for the cameras here. The issue is that I do yoga 3 times a week. And I
So,
find that has actually kept me going for the last 7 years.
do you follow that 150 minutes a week, that kind of exercise?
No. I don't like to measure things. There's something called being penny wise, pound foolish. So people would measure the minutes, but they lose out on the long term. So I usually do, I'm telling you, 3 to 4 times a week. And again, a lot of people tell me that they do yoga.
I appreciate your honesty and I appreciate your practical approach.
Also, I'll tell you one thing. In yoga, if a person just does breathing exercises, he's not going to lose weight. Yeah. I mean, I ask them pointedly, do you do, say, Surya Namaskar? That's the one where your heart rate really goes up, and 12 postures. So you do something where your heart rate goes up.
You celebrated International Yoga Day.
No, I didn't that day. I was traveling. But what I'm saying is that it does have a benefit, I find.
Okay, Philip, what did you do the last?
GSC, I used to walk, quite a bit. Then in Kerala, there's a lot of rain. For the last 1 or 2 months, we've not been able to gain 2 kilo weight. So day before yesterday, I told my wife not to give me any meat for 1 year. And she's happy.
Any meat for 1 year?
Yeah.
Oh my God, wow. This is the one decision of me. I used to enjoy good food in your...
even I used to.
But you eat fish, no?
No, fish I eat, but vegetarian food, once you are used to it, you enjoy it.
Okay, I'm glad that you are telling that. And what about Narasimhan? What did you do? You talk so much about lipidology.
No, I go for walk. In fact, no, I walk on alternate days, and alternate days I do resistance exercise for a period of 1 hour. And I walk for a minimum of 45 minutes, maximum of 1 hour. And except for Sunday, all 6 days in a week.
Okay, you are a very disciplinarian. But one thing I want to draw the attention is all of us, whatever may be the age group, the resistant exercise, the one they recommend, very, very important. The reason is you may remain the same shape, but your fat is replacing your muscle. So make sure that anyone above 50 or 60, you have to do the resistance exercise. I appreciate this. Praveen, what did you do?
Yes, sir. I'm doing a regular exercise, at least 5 days
right
in
now,
a
I'm
week.
watching also. You're doing exercise, moving the chair, moving the
5
chair
days
also.
in a week, sir. So that in a very good.
So you do exercise. Okay, Ashish, what do you do?
Sir, I actually do an exercise other than avoiding the sugar. And what
what did you do?
Yes, sir. Actually, I tried in a different way. My normal walking speed during the working hours, I keep that at just a brisk walking kind
Okay,
of.
you do the brisk
while,
walking. Okay, we'll go to the second round of. I'm sorry to interrupt because we get just a good opinion from you. That all of us we are into some kind of lifestyle exercise. What is the turning point? What do you think the turning point in your life, GC?
We normally wait for an event to occur in life before we actually wake up. And that's the reason why I was tempted to ask that to Dr. Narasimhan. So, there is something called primary prophylaxis, secondary prophylaxis, and so on and so forth. So most people who develop good habits, either they do it out of good common sense or they do it after something has happened to them. Okay. So either way, I haven't had a major problem. But yes, my father died of a first heart attack at 64. So I have to be a bit careful. My sugars are not in the best of state. So I think my wife is a bit of a strict school teacher. So I think that I do my yogas and the food is...
Okay, right. We're coming to the next question. what is the non-medical book you read recently? One immediate and tell me that.
Whom are you asking?
No, I'm asking Narasimhan, starting with Narasimhan. Then I know you are a vivid reader, so I'm asking you last. Narasimhan, what is the non-medical book?
I think sometime back, I don't remember exactly, but I was going through some of the pages. Not that I completed the book. Some
Okay,
of the
right.
pages,
You
which was really
started that.
interesting
Okay.
for me.
Dr. Chawla?
Yeah, the one that I just read yesterday was a book on Doctors Also Cry. That was the heading by a guy known as Ashish Goel.
Okay,
He-
right. I'm glad that we are also putting our efforts. And Dr. Philip?
I'm writing my autobiography.
Okay,
So
okay.
I read one of the classmates who died recently. He had written his autobiography. So I'm just
So you
going
are
through
right. That Balakrishnan also has written one autobiography.
Yeah.
And what about Praveen?
Yes, sir. The non-medical book is The Wings of Fire by our Kalam sir, because that has inspired me most.
Okay, right. Now, what is the the code? What is the book you read, GC? I forgot to ask you.
In fact, the book I think I would recommend all of you. It's called The Authenticity Project. It's written by a British writer.
Yes.
It was listed as one of the 12 very feel-good factor books. And you know why I read it is the word authenticity. So, you know, if a doctor also speaks, if he has done some work or if he has followed something in life, then his words become authentic. Otherwise, it's very superficial. You know, you download from one place and then you put it there somewhere else. So I think that authenticity is a very important issue which I actually have learned to cherish.
Okay, next I will start from you. What is the quotation or quotes really inspires you and motivates you to keep going?
Me?
Yeah.
Well, I think that Louis Pasteur's very famous saying, chance favors the prepared mind. So, you know, we believe that, you know, it's always luck. It's not only luck. You have to be prepared to take the luck.
The chance favors the prepared mind. The Chawla, Professor Chawla, what is the famous quotation?
I don't remember quotes. I read them and I tend to forget.
So forget
So I
that.
won't be able to.
Dr. Philip,
Nothing special.
so all quotes are quotable. Dr. Narasimhan,
You you give the best to your customers, Dr. Mahatma Gandhi.
that is your philosophy. You mean the customer care. Okay, right. Anybody else, Dr. Praveen, you want to say any quotes?
Also, all that glistening is not gold, sir. We have to really find out
Whom are you talking
really
about?
the struggle, which
I
will
think
find
all
out the
are
gold.
glittering. Okay, now you tell me one incident that really changed your life. What incident you will quote? I mean, for good, not that. So starting
sir,
with Dr.
to me?
Chawla, one incident that really changed your life, or one decision that changed your life for good, Dr. Chawla.
To think about it.
Yeah.
Okay, Dr. Philip.
Yeah, in order to join any government institution, straight away go to private sector.
At least you have been telling that. Dr. Narasimhan.
No, in fact, I was interested in teaching, so I joined Stanley Medical College as an honorary assistant professor to render service to the students as well as poorest to the poor. I rendered a free service to the government for 20 years.
Okay, I appreciate that you are teaching and not to join government service. You are not remembering right now. And Dr. GC, what is that incident? My God, I made a good decision that changed my life.
I think that, you know, I have had my time in the government sector. I've worked in Sanjay Gandhi Institute for 25 years, prior to that also. And then one day I decided that, look, I'll now move and see the other sector. So
Okay,
I came to Delhi. I don't regret the decision. I think that, you know, life has to be experienced in many ways. And I think that if you remain too stuck on only one thing, you haven't often seen the others. And therefore, now you don't have an opportunity to see what it feels like.
Fantastic, fantastic. Now, last question is, who is your favorite hero and heroine? You see, while he's thinking, we just finished the answer. Philip, who is your favorite hero and heroine?
I don't watch movies much. I like this.
Okay, you can hero, heroine need not be only in the movie. maybe
Oh,
your father and mother also. So that's how I will catch you. Maybe your daughter also so good that really make it.
yeah, both the daughters.
Okay. And Narasimhan sir, what do you?
Yeah, my daughter, actually, she is a dermatologist.
No, just
She's,
because I gave the clue, you don't have to tell that. Who is your favorite
she's
hero?
too good. She's too good. Yeah.
Okay, right. I think you people are very shy to tell that, Dr. Chawla.
Amitabh Bachchan.
Very good. And heroine?
Mhm. I don't remember. Those yesteryears have gone.
Okay. No, yesterday also you can tell. Who are they?
Just for a change, why not Chandrasekhar tell about his favorite hero and the heroine?
Yeah.
My hero is Amitabh Bachchan in this one, Tamil Shivaji Kamal. And my heroine is yesteryear's actress Sarja Devi and Madhuri Dixit. I'm very clear about that. And GC, what is your favorite hero and heroine?
No, in my college days in Jipmar, it was Shivaji Ganeshan.
Okay, right.
I used to watch the Balachandar movies, and Shivaji Ganeshan, I thought that time was very impressive.
Yeah, very good. Anyhow, ladies and gentlemen, on the viewers from all over the world, this has been a fantastic webinar, and we had two great talk. One from Dr. Narasimhan. He live actually. Somebody will tell you that about Narasimhan. He lives, he everything with the lipid. So, and his talk on lipid metabolism is fantastic. I listened to him. I am very grateful on behalf of the ACG International Webinar. We profusely thank you. And the second speaker, GC, you make always very simple, even the complicated topic, and at the same time very practical. You introduce a lot of new molecules. You are given a lot of homework, and ably moderated by our colleagues, Dr. Chawla and Dr. Philip, and we had a great panelist, Dr. Chaubal and Dr. Praveen Kumar and Dr. Ashish. And this has been endorsed by ACG, American College of Gastroenterology. And we have been doing every fourth Thursday of every month. And we have lined up to March 26th. And next month, don't miss it, pharmacotherapy, more about the obesity and endoscopic and surgical management of obesity. And you would have learned many things from our the faculty, I think, dear viewers and my delegates, that how these all eminent people on the screen who have really proved their worth, and they work very hard and come to this level. And to know more about in the last 10 minutes, we really moved on to this lighter session. And hope you enjoyed it. Thank you very much on behalf of the ACG, and thank you very much.
Thank you, sir.
Thank you,
Thank
DC. Good
Thank
talk.
you.
you, everyone.
Thank
Thank
you,
you.
sir.
Bye-bye. Bye.
Thank you.